Today we will be having a discussion about the Glasgow Coma scale, very famously known as GCS, Glasgow Coma scale. Glasgow Coma scale is actually a tool for a doctor to understand the prognosis of any head injury patient. But it can be used in cases of all those encephalopathies or all those conditions which affect the conscious level of the patient. So it helps to prognosticate any case. There are three components of the Glasgow Coma scale, and these are very famously written as E, M, V. Here, E stands for the eye-opening response, M is for the movement response, and V is for the verbal response. Now, let's take them one by one. First, we talk about the eye-opening response. Eye-opening response. Now, it has got the maximum of the 4 numbers and the minimum of the 1 number. If you see a patient, or you receive a patient, or you attend a patient, and you see the patient has her eyes spontaneously open and purposefully open. If someone has got eye opening which is spontaneous, you give the patient maximum marks, and those are 4. Spontaneous eye opening is given 4. Now, if you go to a patient and the patient is lying on the bed with the eyes closed, and you try to show the presence of you and the family, and the patient doesn't respond to it, then you call the patient by the name or by some like sir, ma'am, and if patient opens the eye on the speech, patient responds to the speech and opens the eye and opens it purposefully, then this is known as eye on the speech. That is given 3 marks. When someone is spontaneously opening the eye, those are given the 4 marks out. And if someone is not actually spontaneously opening the eye but responds to the speech or responds to your verbal commands, then you give 3 marks. If patient doesn't even respond to your verbal command, then you give a painful stimulus to patient, and by painful stimulus I mean either you would put the pressure on the sternum, upper part of the sternum, or above the eyebrows. If patient responds to painful stimuli and opens the eye, we call it painful stimuli. We give it 2 marks. And even in spite of doing all this, patient doesn't respond, patient doesn't open the eye, you give only one mark. None is given 1. So let's recap it. Eye opening response has got the maximum of 4 and the minimum of 1. If patient is spontaneously opening the eye, you give the 4 marks. If patient is not spontaneously opening the eye and responds to your commands, like you ask the patient, please open your eyes, then you give 3. If patient even doesn't respond to your speech and you give the painful stimulus and patient opens the eye, you give 2 marks. And even if patient is not responding to your painful stimuli, you give only 1 mark. So this is the first component of the EMV, eye opening. Now we go to the second component, which is motor response. Motor response. Motor response is one of the most important response in evaluation of the GCS, and it has got the maximum of 6 number and a minimum of 1 number. If you go to a patient and you ask the patient, please open your eye, lift your hand, take out your tongue, and patient is actually following or obeying your commands. When someone is obeying your commands, you give the maximum number of 6. But if patient is not obeying your commands, then you give the same painful stimulus either on the upper part of the sternum or on the above the eyebrows, or the forehead. Then if patient responds by trying to just have have a grip on your hand or grabs your hand or is trying to actually localize the area where you are giving the painful stimulus, then this is known as localization response. And localization response is given 5 marks. So obeying was 6 and localization is 5. But if patient doesn't localize the painful stimulus, but when you give the painful stimulus, patient flexes as very properly as if patient is about to come to your hand where you are giving the painful stimulus. Then patient tries to pull it away. Patient withdraws it. We call it flexor withdrawal. Like as if something is stopping the patient from getting a hold on your hand, which is giving the patient a painful stimulus. So this is known as flexor withdrawal. This is flexor withdrawal and we give it 4 marks. Flexor withdrawal and it's given 4 marks. Now, even if the patient is not having the flexor withdrawal, you give the painful stimulus and patient only flexes on these joints or flexes the limbs, then this is the last hopeful sign. Flexion is given 3 marks. As per my personal experience, as long as a patient shows you the flexion response, there are chances that ultimately this patient will come back and will make it to the normal life, can be up and about after whatever the time period is. But once patient loses this one, patient drops down to the notorious sign, a sinister sign of outward movement on these joints. This is known as extension. Extension is given 2 marks. When there is a extensor response, that means things have gone all the way down to the brainstem and the only part of the brain working is medulla, and the higher centers like it was up to the hypothalamus when the patient had flexion or flexor withdrawal. When it came down to flexion, the upper midbrain and the pons were involved. But when patient is localizing or obeying the commands, cerebral cortex is dysfunctional but it's working. So it's a very important point to understand that GCS is not only the digits, it actually gives a way to actually look into the brain of the patient and its functioning. So extensor is a bad sign, and that if patient doesn't move in response to your painful stimulus, then you give 1. None mean 1. So let's recap the motor response. When patient is obeying your commands, you give 6 marks. When patient localizes the painful stimulus, you give 5 marks. When patient does the flexor withdrawal, this is patient is given 4 marks. When simply patient is flexing the limbs, patient is given 3 marks. When there is extension, which is a bad sign, up till the flexion things can go back. So extension is given 2 marks, and when there is no response, it's 1. So whenever a patient has gone into the extensor, there are chances that patient can survive, but the chances of getting up and about are almost negligible. Okay, so now we move to the last, which is the verbal response. Verbal response is given maximum of 5 and minimum of 1. Maximum of 5 is when you talk to the patient and you ask patient, what's your name, where you came from, what is this place, can you look out and tell what's the daytime or nighttime, whether this is the day or the nighttime, who's standing by your side, who I am. If the patient is oriented in time, place and person, you give the maximum marks. An oriented patient is given 5 marks. Now if you talk to the person or the patient, and patient is actually knowing what you are asking but is giving you a wrong answer. For example, you ask patient, what's your name? Patient's name is Shahid, but he's giving you the name like I'm Sadiq. So patient is actually understanding what he's being asked, but he's giving you a wrong answer. If you ask him where he is, patient is actually in the hospital, but he tells that I'm in the playground, I'm on the railway station. So patient is confused. Patient is understanding what is being asked but is given wrong answers. Confused. Patient is given 4 out of the 5 verbal response. Now there is a very interesting downgrading from 4 to 3 in a condition where you ask patient what is your name. Now you are asking name, but patient is not understanding what you are asking. Is sort of trying to lip read you, is trying to understand, but doesn't know what are you asking, and give you an answer which has which hasn't got any relation with your answer. For example, you ask what's your name, and patient gives you an answer, yes, I came on my motorbike, on my car. You ask patient who's this person, and the answer is yes, I had eaten my meals. So these words are inappropriate. These are not the appropriate answers. So the downgraded category goes to the inappropriate words, which is given 3 marks. Inappropriate words is given 3 marks. Now there comes another category where patient is only producing certain voices, like let me do it. These hasn't got any words. You cannot comprehend them. These are incomprehensible sounds. These are incomprehensible sounds. These incomprehensible sounds are given 2 marks. And if there is no response from the patient side, you ask patient, whatever you say to the patient doesn't respond to you anyway verbally, you give 1 mark. So let's recap it. The verbal response: if patient is oriented in time, place, and person, he's or she's given 5 marks. If patient is confused, doing the confused conversation, you give 4 marks. If patient is having inappropriate conversation or the words, you give 3 marks. If patient is producing incomprehensible sounds, you give 2 marks. And if there is no response verbally, you give 1 mark. Okay. Now there are 2 extremes. A normal person like you and me has got a GCS of 15 by 15. 15 by 15. And a dead body has got a GCS of 3 by 15. Because we never give 0. We always give the minimum of 1. Because if we give 0, everyone knows that the brain death cannot be ascertained solely on the GCS. So the people who devised this tool have very wisely actually done so, and they haven't given the 0. So the dead body or the lowest is 3 by 15, and the more normal is 15 by 15. One category is 12 to 15 by 15 is known as, so let me do it, 13. There are 3 categories, 13, 14 and 15 by 15 is known as a minor problem and excellent prognosis. Minor problem and excellent prognosis. Excellent prognosis. But a category falling between 8, 9, 10, 11 and 12. So it goes out from here, okay. 9, 10, 11, 12 by 15 is known as moderate problem, and guarded prognosis. Guarded prognosis. Actually, what you mean by that? I mean that if patient has got a GCS of 13, 14 or 15 by 15, you can assure the family of the betterment and sooner. But in case like someone has got a GCS of 9, 10, 11 or 12 by 15, you can ask the family that there is a problem and chances are patient can improve, but there are chances that patient cannot improve. So it helps you to prognosticate the patient based on the GCS. But if the GCS is 3 by 15, 4 by 15, 5 by 15, 6 by 15, 7 and 8 by 15, it means the problem is huge and prognosis is poor. A GCS less than 9 is always a problem. So a GCS 3 to 8 by 15. 3 to 8 by 15 means critical condition and poor prognosis. And always try to write down GCS in a learned way, in an educated way. EMV. For example, let me wipe it off. Let me tell you how to write down GCS. For example, we receive a patient and who's got eye opening on a painful stimulus. We will write down E2. Eye opening on painful stimulus. Patient has got flexor withdrawal. We'll give M4. And patient is producing incomprehensible sounds. That would be V3. So if I make it total 4 to 6 and 9, it would be 9 by 15. Patient is falling in the moderate category, but this is the best way of writing down the EMV or the GCS of the patient. And one very important thing, whenever a patient has got an endotracheal tube or tracheostomy, try to write down, instead of the V, write here E2, M4, ETT or E2, M4 if patient has been passed tracheostomy, TT. And here you will write down this way. 4 and 2, 6. 6 tracheostomy tube by 15. So this is the best way of mentioning GCS. Now, one last important thing. And in any patient who's got a GCS of 9 by 15 or less than 9 by 15 is probably not able to take care of the airway, and patient will need an advanced airway, endotracheal tube or tracheostomy tube. So this also helps you to understand this thing, that if a patient has got a GCS like 9 by 15 or less than that, better you pass endotracheal tube, because otherwise in our practical life, personally I working in ICU for last many years, I have received so many patients which I'll have to pass ETT based on this factor that their GCS was no more than 10 or 9 and they already had aspirated the gastric contents into the lungs. And one very important factor which comes to mind, if a patient is coming from another hospital, why they haven't intubated the patient? Why? Because they haven't got a good idea about the GCS. Because if a GCS is compromised, it's for sure that ultimately the patient will aspirate the gastric contents, and that will make the problem huge and huge and huge. I hope it gives some idea of Glasgow Coma scale. It's combination of the three words. Glasgow is the capital city of the Scotland. Coma is a state of unarousability. Daily we go into the coma. We sleep at night, but we ultimately wake up in the morning. But in coma, patients don't wake up. When they'll wake up, nobody knows. Scale is a grading system where you have certain digits to actually prognosticate. You have the highest, lowest and the middle ranking. So this gives a better idea of GCS or